Okay, thank you very much, and good morning, everybody. Again, it's a great pleasure and honor for me to be here in South America to share with my experience. So there is no conflict of interest for this presentation. The first problem is what is an irreparable cuff tear, and you can see on this movie that it is a massive cuff tear. The soft tissue is very weak, but there is a deep layer. But you can see that after a few minutes of surgery, you can reduce the cuff and you can fix it. So this is a massive cuff tear, but the repairable is possible. This is the first point. The second point, before the surgery, sometimes it's possible to know whether you will be able or not to repair your cuff. First, just look at the back of your shoulder, and if you see an atrophy of a muscle belly, you can see that probably it's a bad predictable factor to repair. I don't say you don't have to repair, but it's a bad predictable factor. Again, if you see the decrease of the subacromial distance less than 6 millimeters, probably the teres minor is involved in the tear, and probably you will have a bad result with your repair too. So you have exactly the same idea with the Hamada classification. As soon as you have the stage 3 with balloonization of acetabilization of the acromion, probably it's a bad idea to try to repair your cuff. Even if you're able to repair, probably it's a bad idea. But yes, you have a fat infiltration too. And after the grade 3 or 4, don't try to repair because it will not work. It cannot work. One point, this is a French study, very recent French study. And you know that now if your patient has more than 5 risk factors, 5 vascular risk factors, the risk of retear is 100%. So as soon as you have some smoke, cholesterol, hypertension, diabetes, obesity, and so on, do not repair. 5 risk factor means 100% of risk of retear. And the last point is you are not better than your friend. And if the patient has already been operated on previously, like in this situation, don't try to repair again. Probably there is a biologic problem with your tendon, and it's a bad idea to try to repair again. So regarding that, we have to, oh, sorry for this, for this video. Thoracic shoulder, when we travel in the world, especially in the USA, we have not the same definition of the thoracic shoulder. The range of motion passive is normal, but there is no active one. And we have to separate the acute cases after a trauma, where you can repair the cuff in emergency, and the chronic cases after 6 months or 1 year, when even if you try to repair this cuff, you will not be able to have a good result. And massive is not supralytic because you can see this patient had a normal range of motion but no cuff, and you can have a normal range of motion without any cuff. These two patients has exactly the same X-ray and the same cuff. One is working, the other one is not working. So the question is what happened between these two patients? One, why the one is correct and the other one is not correct. So we have to try to understand what is the link in between. And you see, for example, this patient who has a deficit of elevation but a good external and internal rotation. Pascal Boileau have defined this like a highly isolated loss of elevation. It is a vertical imbalance of the shoulder. On the opposite, this is a deficit of external rotation. The elevation is normal, the patient has no pain, but there is no external rotation and the patient has some problem to drink a glass of water. There is no infraspinatus, there is a weak teres minor, there is a good subscap. In this situation, it is the isolated loss of external rotation. And you can have both a vertical, you can have both a vertical and horizontal imbalance of the shoulder. It is the clear. And in that situation, when you have an involvement of the supra, infra, and teres minor, the risk of having a pseudopathic shoulder with a posterior superior escape of the shoulder is 1 patient out of 3. And on the same way, if you have no subscap and no supraspinatus, if it's the type B of Philip Collin, the risk of having a superior escape, an anterior and superior escape, is 80%. So when you have no subscap, this is probably the subscap, it was the most important muscle on the shoulder. So to sum up, this is the work of Pascal with the highly, the clear, and the hilar. But in the classification, Pascal forgot to talk about the deficit of internal rotation, and I've described the isolated loss of internal rotation. And in fact, this is just an hypothesis, but for me, maybe the real new definition of a pseudopathic shoulder may be the two directions of a deficit. When you go to the center part of his diagram, and you are close to what we could call the pseudopathic shoulder. But if you talk about the deficit of elevation, I think you have two types. You have this one, I call the highly type 1. So the patient has some pain, and because of the pain, she's not able to have a good elevation. But she's able to do that. On the opposite, this patient is the evolution, I think, of the first case, and it is what we could call the highly type 2, or the total highly, and we know that it is the full deficit of elevation. And when you have a problem of vertical imbalance, I think you have two different patients, and it is very important. For the highly type 1, so when the pain is the main problem, I think the lat dorsal transfer is the best way to treat such a patient with a posterior fixation of the lat dorsal, not an over-the-top one. And I published my result. On the opposite, and this is very important to understand, because of the biodynamic and the labor arm of the humerus, if you, the center of rotation of humerus and is on the humeral head, if you put 1 kilo onto the elbow, you need 10 kilos of counterforce to rebalance the shoulder. Because of that, and you have to remember that the weight of the upper limb is 6% of the body, and it's not possible with just a tendon transfer to reactive that. You try to understand that to elevate the shoulder, you need a very big strength. But for rotation, you do not need so many strengths. Because of that, the highly type 2, I agree with Pascal Boileau, the best treatment is not a tendon transfer, is a reverse shoulder arthroplasty, because with the biomechanic, you can readapt and reinforce the deltoid. Now how to rebalance the external rotation? This one. So in that situation, you have three possibilities. You can propose the lower trapezius transfer, you can propose a teres major, and you can propose a lat dorsal plus or minus the teres major. So what is the best one? The three are possible, but we know with Hassler and Bassem, of course, that if you want to recreate the EA1, the arm at the body, the best transfer is the lower trapezius transfer. So for the hilar, deficit of external rotation, I think the best transfer is the lower trapezius, not the lat dorsal. Now, what about the hilar, the deficit of internal rotation? I increase my speed. You have three possibilities, the pec major transfer, the pec minor transfer, and you can make the lat dorsal. Bassem will show you that the lat dorsal is the best way biomechanically for that, and we published this together 2 years ago. So when you have now a vertical and horizontal imbalance of the shoulder, like this patient, I agree totally with Pascal, we have to propose a reverse plus tendon transfer, and I think the best one is the Lepiscopo procedure, because you make a deltopectoral approach and it's very easy to turn around. And now, how when you have a deficit of elevation and interrotation, the clear eye, and I think just a reverse is enough, and maybe you can add a transfer of a pec major, like G.D. Wertel has proposed few years ago, to restore interrotation too. So in conclusion, this is my first conclusion. When you have an isolated, when you have a non-pseudopathic shoulder, when your shoulder is functional, it is the field of the isolated tendon transfer. Loss of elevation because of pain, you propose a lat dorsal. If you have loss of external rotation, hilar, you can propose a lower trapezius transfer. For me, it's the best indication. When you want to recreate the ER2, I think the lat dorsi is better, but the discussion is open with my friend Bassem. And if you have no interrotation, the best transfer is the lat dorsi. Now, on the opposite, if you have a real pseudopike shoulder, this is the field of the reverse plus a tendon transfer. So loss of elevation, totally loss of elevation, highly of Pascal Boileau, isolated reverse is the choice. If you have a combined deficit vertical plus horizontal, a reverse is not enough alone. You have to propose, in case of clear, a reverse plus a Lepiscopo procedure, a lat dorsi, or in case of loss of elevation plus interrotation, the clear reverse plus or minus pec major transfer. Thank you very much and welcome for Le Mans Shoulder next year.